Welcome back to This Week in Pulmonary and Critical Care Medicine. I'm your host, Dr. Aladdin Sagar. For busy clinicians, this is your weekly pause to step back from the wards and look carefully at what new data actually add to practice. This week's studies move across three connected layers of care. We start with a population-level question that challenges long-held assumptions about reflux and lung disease. We then move into the ICU, examining how protocolized peripheral vasopressor use can change invasive practice patterns at scale. And finally, we zoom out to a higher-order clinical problem, pulmonary hypertension and interstitial lung disease, where physiology, diagnostic nuance, and restraint matter more than reflex treatment. Together, these papers ask a shared question: when do associations justify action, and when does thoughtful selection matter more than intervention? Let's begin. For years, nocturnal gastro-oesophageal reflux has been treated almost reflexively as a pulmonary risk factor. The biological story feels intuitive: microaspiration, airway irritation, chronic inflammation, and has shaped real prescribing behavior, especially in interstitial lung disease. But intuition is not evidence, and this study asks whether reflux actually leaves a detectable structural footprint in the lungs. Published in Thorax in January 2026, this analysis comes from the Swedish CArdioPulmonary BioImage Study, a large population-based cohort designed to examine early cardiopulmonary disease. The investigators analyzed 28,846 adults aged 50 to 64 years who completed reflux questionnaires and underwent standardized low-dose chest CT imaging. Nocturnal reflux was defined conservatively, symptoms occurring at least one night per week. The prevalence of nocturnal reflux in this general population was 9.4%. A reminder that this exposure is common even outside pulmonary clinics. CT scans were evaluated for bronchial wall thickening, bronchiectasis, reticular abnormalities, ground glass opacities, honeycombing, and cysts, using harmonized radiologist training across 6 centers. When the cohort was analyzed as a whole, the key result is striking in its restraint. Nocturnal reflux was not independently associated with pulmonary abnormalities on CT. After multivariable adjustment for age, sex, BMI, smoking status, asthma, inflammatory bowel disease, autoimmune disease, education level, and study center, the signal largely disappeared. However, the story changes subtly, but importantly, once background risk is introduced. Among participants with predefined pulmonary risk factors, ever smoking, current asthma, inflammatory bowel disease, or systemic autoimmune disease, totaling 4,004 individuals, nocturnal reflux showed a modest association with specific findings. Bronchial wall thickening was more common, with an adjusted odds ratio of 1.25. Reticular abnormalities were also more frequent, with an adjusted odds ratio of 1.51. Interestingly, cysts were less common, with an adjusted odds ratio of 0.68. Among participants without pulmonary risk factors, numbering 2,555, nocturnal reflux showed no association with any CT abnormality. Several aspects of this paper deserve emphasis. First, this is not a referral population. These are not patients selected for cough, fibrosis, or dyspnea. Second, nearly half of individuals with CT abnormalities had no respiratory symptoms, underscoring how easily imaging findings can outpace clinical disease. And third, adjustment for antacid use, present in only 4.4% of a metabolomics-confirmed subgroup, did not meaningfully change the results. The takeaway is not that reflux is irrelevant, but that it is not sufficient. In otherwise healthy individuals, nocturnal reflux alone does not appear to drive structural lung disease. Where risk already exists, reflux may act as a weak modifier rather than a primary cause. This challenges the habit of treating reflux to protect the lungs without clear pulmonary indication. Central venous catheters are so embedded in ICU culture that their risks are often treated as unavoidable. Yet every line placed carries mechanical, infectious, and thrombotic consequences. This study asks a practical question with system-level implications. Can changing how we give norepinephrine meaningfully reduce central line use? Published in Chest Critical Care, this single-center observational study evaluates the impact of a protocolized peripheral norepinephrine strategy in a large academic medical ICU. The protocol was introduced in March 2019 and allowed norepinephrine to be administered peripherally under defined conditions: lower concentration, 8 milligrams per 250 milliliters, a maximum dose of 0.5 micrograms per kilogram per minute, a maximum duration of 48 hours, frequent line checks, and staff education on extravasation recognition and phentolamine rescue. The investigators compared central venous catheter utilization before and after protocol implementation, spanning July 2017 through December 2023, and used a difference in differences design with other ICUs in the same hospital serving as controls. The results are concrete. Before the protocol, 59.5% of medical ICU patients received a central line. After implementation, that proportion fell to 53.5%, a statistically significant reduction. Over the same period, central line use in control ICUs remained unchanged at approximately 61%. The difference in differences analysis estimated a 7.0% absolute reduction in central line placement attributable to the protocol. Given an average monthly census of 199 admissions, this translated into roughly 14 fewer central lines per month. The patient-level data reinforced the message. During the post-implementation period, 819 peripheral norepinephrine infusions were administered. Of these, 391 patients, 47.4%, never required a central line during their ICU stay. Importantly, adverse events were rare. Only 9 patients, or 1.1%, required extravasation treatment, and all were managed without long-term harm. This study does not argue that central lines are obsolete. Many patients still require them for duration, dose escalation, or access needs. What it demonstrates is that default behavior matters. By legitimizing peripheral vasopressors through protocol, education, and safeguards, the ICU shifted away from reflexive invasiveness. The broader implication is cultural. Risk reduction here did not come from a new drug or device, but from redefining what is considered acceptable first-line practice. That same principle, precision before escalation, becomes even more critical when we approach complex diseases like pulmonary hypertension in interstitial lung disease.
Pulmonary hypertension in interstitial lung disease sits at the intersection of two failing systems: damaged lung parenchyma and a stressed pulmonary circulation. What makes it difficult is not recognizing that pressures are high, but understanding why they are high and whether that mechanism is modifiable. Published in Chest, this How I Do It review approaches ILD-associated pulmonary hypertension by stepping away from labels and focusing instead on physiology, sequence, and consequence. It uses a longitudinal case to illustrate how pulmonary hypertension emerges in ILD, how it should be evaluated, and, just as importantly, when treatment aimed at the pulmonary vasculature is unlikely to help. The first principle is prevalence and proportionality. Severe pulmonary hypertension occurs in roughly 5 to 10% of patients with fibrotic interstitial lung disease, though this number rises dramatically in certain phenotypes, particularly combined pulmonary fibrosis and emphysema, where prevalence may approach 50%. When pulmonary hypertension develops, outcomes worsen substantially. Mortality in ILD-associated pulmonary hypertension is estimated to be more than 3 times higher than in pulmonary arterial hypertension without underlying lung disease. This excess risk reflects not just elevated pressures,
but the limited physiological reserve of a fibrotic lung. Understanding mechanism is essential. In ILD, pulmonary hypertension is rarely driven by a single pathway. Chronic hypoxemia leads to sustained hypoxic vasoconstriction. Progressive fibrosis reduces the available pulmonary vascular bed. Inflammatory signaling promotes vascular remodeling. At the same time, common comorbidities, left heart disease, venous thromboembolism, sleep-disordered breathing, layer additional hemodynamic stress. The result is a pressure elevation that is often adaptive early, maladaptive late, and frequently mixed in origin. This complexity explains why screening tools perform poorly. Transthoracic echocardiography, while attractive, is limited in ILD. Acoustic windows are often inadequate, and right ventricular systolic pressure cannot be estimated in up to half of patients. Even when measurable, echo-derived pressures correlate weakly with invasive measurements. Biomarkers such as BNP or NT-proBNP track risk and prognosis, but lack specificity, rising with right ventricular strain, left heart disease, renal dysfunction, or acute ILD exacerbation. Rather than relying on a single test, the review emphasizes patterns over thresholds. A disproportionately reduced DLCO relative to lung volumes, a rising FVC to DLCO ratio over time, declining 6-minute walk distance, worsening exertional desaturation, or an enlarged pulmonary artery on CT imaging should raise suspicion. Importantly, these signals gain meaning when they evolve longitudinally, not when viewed in isolation. Timing matters. Acute ILD exacerbations can transiently raise pulmonary pressures through hypoxia and inflammation alone. Evaluating pulmonary hypertension during instability risks misclassification. The authors stress that diagnostic confirmation should occur when patients are clinically stable after reversible contributors have been addressed. Right heart catheterization remains the anchor for diagnosis, but even this is nuanced in ILD. Using current definitions, mean pulmonary artery pressure greater than 20 millimeters of mercury, pulmonary capillary wedge pressure equal or less than 15 millimeters of mercury, and pulmonary vascular resistance above 2 Wood units, clinicians must still distinguish precapillary disease from postcapillary or mixed physiology. In ILD, respiratory swings make wedge pressure measurement unreliable. Averaging across respiratory cycles and, in select cases, directly measuring left ventricular end diastolic pressure may provide more accurate classification. Treatment follows mechanism, not numbers. The foundation of care is always optimization of the underlying lung disease, antifibrotic or immunosuppressive therapy when appropriate, correction of hypoxemia, pulmonary rehabilitation, vaccination, and early transplant referral. These interventions address the dominant drivers of pulmonary vascular stress. Pulmonary vasodilator therapy, by contrast, targets only a subset of patients and carries real risks, including worsening ventilation-perfusion mismatch. The review reinforces that such therapies should be reserved for carefully selected patients, ideally within specialized centers. The central teaching point is restraint guided by physiology. Elevated pulmonary pressures in ILD are common, but not all pulmonary hypertension is a treatment failure. Often, it is a signal of advanced parenchymal disease, where the most effective intervention is not escalation of vasodilators, but alignment of care with realistic physiological limits. This framing, understanding when association reflects mechanism and when it reflects disease severity, echoes the lessons from the earlier.
This week's papers remind us that good medicine often means doing less, but doing it better. Reflux does not mandate lung treatment without risk context. Vasopressors do not mandate central lines when safer alternatives are structured. And pulmonary hypertension in ILD does not mandate reflex vasodilation without physiological clarity. Thank you for spending this time with us. If you find these discussions useful, subscribe and share with colleagues. We'll continue to slow the literature down so it can be used wisely. Until next week.